everyone. Good morning. Um, so today I'll be talking about a topic that I think is super, super cool. These are devices that are all kind of in the phase one territory. So remains to be seen where things are going to go with this. But I think if we're lucky, it could be a kind of a new era of how we manage a lot of challenging volume situations in cardiorenal syndrome. So let's do this. Uh, so acute heart failure or acute decompensated heart failure, cardiorenal syndrome. Um, Decompensated heart failure makes up 2 million hospital admissions annually in the US. And about 30% of those patients will experience what we call worsening renal function, which is an intentionally vague term because it can be hard to interpret what a change in creatinine really means. But it does show just how often it is to see changes in creatinine during these types of admissions. Now, cardiorenal syndrome itself is a complicated interplay of essentially harmful crosstalk mechanisms between the heart and the kidneys. The kidneys handle a larger proportion of cardiac output than other organs proportionately, or per capita, if you will. So they take about 20% of the cardiac output. So the organs are quite connected. If you have an acute cardiac event, like an MI, a decompensated heart failure, etc., or even an acute renal event like AKI, or a chronic issue with either organ's function, you essentially get a cascade of events. Reduced cardiac output or elevated central venous pressures from hypervolemia lead to reduced renal perfusion. You get activation of the neurohormonal axis, specifically sympathetic nervous system, renin, angiotensin aldosterone axis, which leads to enhanced renal sodium avidity, which then kind of worsens everything. You get electrolyte discrepancies, imbalance of sodium and water homeostasis, endothelial dysfunction, inflammation, cytokine-mediated microvascular damage, and ultimately you end up with both renal and cardiac fibrosis and both tubular and ventricular remodeling. One of the big concepts in cardiorenal syndrome is renal perfusion pressure. And that's based on the fact that the two hemodynamic measures that most consistently correlate with worsening renal function are mean arterial pressure and central venous pressure. Renal perfusion pressure is defined as the MAP minus the CVP, and it's a simple idea of renal preload and renal afterload, in a sense. Stealing terms from cardiology. Uh, um, and one of the big problems is that the kidney is encapsulated. It's not an elastic organ. So if you have glomerular or renal interstitial congestion, that's pretty problematic, and it enhances why MAP and CVP have such a profound impact on renal perfusion. So there are three main mechanisms of renal hypoperfusion in the context of an acute decompensated heart failure situation. First, you have venous congestion, elevated central venous pressure, which via reduced renal perfusion pressure will worsen renal sodium avidity, neurohormonal activation, inflammatory pathways, and we tend to consider that one of the central problems in cardiorenal syndrome. The second is arterial underfilling, where if you have a low MAP, or in cases of cardiogenic shock, you have a very reduced cardiac output, you can get ischemic tubular injury, and that too can lead to problems of sodium avidity, inflammatory activation, cytokine-mediated damage. And finally, you have interstitial overload, where if you have reduced removal of fluid through the lymphatic system, you ultimately end up with less sodium presented from the microcirculation to the macula densa, because a lot of that sodium is trapped in the interstitium. And so that too worsens neurohormonal activation. So all of this essentially becomes a self-propagating vicious cycle. And traditionally, worsening renal function was simply thought to be overdiuresis. And I think there's still many who think that way. But worsening renal function is a little different from real AKI because it can represent different things. And I like this Venn diagram on the top because it shows different situations uh, and how they can have very different clinical implications. So if you look at one over here, a person could be euvolemic and it looks like they're having diuretic resistance and rising creatinine, but it's because you've actually over-diuresed them. So yeah, that does still happen. Um, as I've been doing more general consult, I'm coming to realize that people can be hypovolemic, and it's a struggle for me. But um, number two is you could have someone who has stable renal function, but they have significant diuretic resistance and ongoing volume overload. And yeah, the creatinine isn't going up, but that's actually going to be very harmful for both renal and cardiac outcomes in the long term. Then number three, you could get worsening renal function with appropriate diuresis, in which case you keep going, because that's going to correlate with better long-term cardiac and renal outcomes. And then, of course, you've got sort of true CRS, the worst of all worlds, where um, you have diuretic resistance, you have congestion, you have worsening creatinine, and those are some of the tough, situations where decongestion becomes a big priority. On top of volume, there are other issues to contend with. Cardiac afterload uh, is an issue because if that's very high, that directly can reduce cardiac output. And so there, sometimes you have to use vasodilators to relieve that. Then you also have the issue of um, normal SVR, but the myocardium is just so weak that the cardiac output is reduced. Those are situations where you need inotropes. And then you have complicated situations where the right ventricle is failing and or severe pulmonary hypertension, where depending on the acuity, you may have some degree of preload dependence. And then never mind situations like ascites, high intra-abdominal pressure, pericardial effusions, tamponade, which can affect the entire system. So currently, the main way we treat cardiorenal syndrome is through diuretics. And there's been many studies looking at continuous bolus dosing, escalation of dosing, um, and that have been pretty cardinal in what we do. And diuretic resistance poses a major challenge. I'd say that's pretty much the biggest thing that we work on kidney heart service. And we think of things like distal convoluted tubular remodeling, issues of diuretic absorption, issues with hypoalbuminemia, and the fact that we don't really have a means to fix that. People that just have low GFR, so they're not going to respond. And our main strategy for dealing with this is sequential nephron blockade, thiazides, SGLT2s, acetazolamide, etc. Um, but while this can work very well, you do end up with greater creatinine changes, greater electrolyte risks, and sometimes it just doesn't work, and you're stuck with dialysis. And despite all of what we've done so far in terms of working on diuretic resistance, 3-month rehospitalization rates are still abysmal. They're about 30%. So some unfortunate statistics are that 90% of decompensated heart failure admissions don't achieve euvolemia within the first 4 days. 60%, the majority of these patients are discharged with persistent hypervolemia, even in the most recent trials like ADVOR, which were, touted to show that you can add another diuretic and potentially decongest them earlier and more reliably. Still, about 20% of patients had continued signs of congestion at the time of discharge. And then there's the sad fact that diuretics, especially loop diuretics, are a double-edged sword because they worsen neurohormonal activation by blocking the NKC channel. So you're using them because you have to, but the broader problem of renal sodium avidity is not being taken care of. If anything, it could be worse. So there was the idea of extracorporeal UF. The CARESS HF trial is the most famous in that regard. And you know, it worked. There was some decongestion, but it wasn't really superior to pharmacologic diuresis. You had elevations in creatinine even more than with pharmacologic diuresis. You have to contend with the fact that people who have RV failure and even just HFpEF have a higher risk of hemodynamic compromise when you're doing things like UF. And some people got creative and came up with salt-free PD, where you use 10% dextrose, and you do get a much greater removal of UF than a standard 4.25% solution, but you still end up with problems like hyperglycemia. There's concern for peritoneal protein loss, which can be an issue when someone is critically ill, which, to be fair, is pretty much the only context that this is really being done. For myocardial dysfunction, we use inotropes, but those increase the risk of arrhythmia. Those increase myocardial oxygen consumption. Just like diuretics, they act as a bit of a double-edged sword. And I didn't put a slide on this, but vasodilators for afterload, all well and good, but anyone who's rotated on the kidney heart service knows how many times you get someone whose map starts going into the 50s and creatinine is getting worse, and everyone's happy about afterload reduction, but you're actually getting worse tubular function. So essentially, there's something inherently wrong with everything we do. That's true of all of medicine to some degree, but it's particularly true in cardiorenal syndrome. So that brings us to this new concept of renal assist devices. And this is kind of a busy slide, but I'm going to go into a lot of depth on all of this. And the idea with a renal assist device is you want to restore renal perfusion pressure, but you want to do it in a way that doesn't compromise neurohormonal activation, hemodynamics, electrolytes, or myocardial oxygen demand. And of these devices, they come in 4 flavors at this point under study. So I'm going to go through examples of each one. In my opinion, in order of what I find interesting, but that's my opinion. Anyway, so first we've got systems that work on neurohormonal modulation and monitoring and balancing. So there's a system called the Reprieve system. This is a device that's connected both to a Foley catheter and a peripheral vein. What it does is it measures urine output while also giving replacement fluid. So it's similar to a CRT in a way, but it's not doing any UF. It's just a monitoring system that's looking at how much urine is coming out and giving what they call a therapeutic amount of saline that's set by the clinician to achieve a certain fluid balance. Now, this seems kind of weird, like, oh, you don't really want to give fluids to someone you're diuresing, but their concept here is that this takes care of any concern over the refill rate from diuresis, uh, from over-diuresis, that is. So you don't have to worry about reequilibration between interstitial spaces and the intravascular space. And you're essentially giving a continuous amount of chloride while you're diuresing, with the hope that you're balancing the effects on neurohormonal activation. Interestingly, in the one study I could find on this, where they looked at 84 patients, they found that compared to the preceding 24 hours where they were just on diuretics, in the 14 to 30 hours with the Reprieve system, there was actually effective fluid loss of about 5.5 kilos, plus or minus 2, over a 14 to 30 hour period, which was significantly more than what they were getting on diuretics alone. Next device of interest is cardiopulmonary nerve stimulation system. So this goes into the right pulmonary artery, and it stimulates a plexus of nerves called the cardiopulmonary plexus. When you stimulate that, you get natural improvement in LV contractility. So this was studied in 15 patients that did show that when you stimulated this nerve bundle, you had about a 23% increase in LV contractility. You had an increase in the MAP, but you didn't get a significant increase in the heart rate. And the hope with this is that you're bypassing some of the downsides with inotropes, where you do have an increased risk of arrhythmia. Next device is a catheter-based splanchnic nerve ablation. Um, I'd imagine that this is a nightmare for anyone dealing with hepatorenal syndrome, but for cardiorenal syndrome, the concept here is that about 25% of the venous fluid is in the splanchnic system. And then that splanchnic system acts as a reservoir that's heavily innervated. In states of stress, fluid can be mobilized from the splanchnic system to contribute to venous return. But in decompensated heart failure, that's not really a good thing. That happens, but it serves to worsen venous congestion and increases right-sided filling pressures in the heart. So the idea with this device is that you want to ablate that nerve and prevent venous splanchnic constriction, reduce cardiac preload during decompensated heart failure. So they did a pilot study of 11 patients with HFpEF, and that had a wedge of greater than or equal to 15 and class 2 or higher New York heart failure class CHF. And what they found was that there was a reduction in mean wedge by about 8 without causing hypotension. And on the long term, they found an increase, or rather a decrease in the heart failure class and in NT-proBNP over time. So moving on to what I would argue are currently, of these 4 sets of devices, the ones that have advanced the most in terms of trials and have some of the most data, and that's what we call pushers. So the idea with a pusher is if you can increase renal arterial pressure locally, you could get more diuresis and lower the CVP in a way that doesn't worsen neurohormonal activation because you're not using a diuretic, possibly even improves it because you're getting more flow to the macula densa without blocking the NKC. On top of that, you could reduce pressure at the aortic root, reduce afterload, and increase cardiac output without worsening myocardial oxygen consumption. And these are particularly could have a role for people who are not candidates for ventricular assist devices due to HFpEF or a small LV cavity or mechanical valves. So the most well-studied device in this category is the aortic's Procerion device. The way this works is it's an axial flow device. So it's threaded through the common femoral and put into the descending aorta above the renal arteries. It has an external driveline with a motor controller similar to an LVAD. And it uses the concept of fluid entrainment, which I have to say, I tried to understand the physics of this and it's beyond my, so I'm going to give a basic concept of it, which is probably not super accurate. But my understanding is that essentially blood enters this pump. It exits in a high velocity jet. And then the momentum from that jet is transferred to blood that's flowing passively around the pump. So you essentially enhance flow past the pump, but in a way that's pulsatile. These devices use pretty high speeds, like about 25,000 RPM. So the first human trial was done in a patient with decompensated heart failure, cardiorenal syndrome, EF of 17, CVP of 26, wedge of 33. Patient had already been on high dose of Bumex, metolazone, dobutamine. And essentially when they put this device in, their diuresis improved from 1 liter per day to 7 liters per day within 3 days. There was a 35% increase in cardiac output. The MAP dropped from 79 to 67, which I know renally we're like, wait, is that a good thing? But good thing in this case for afterload. The wedge dropped from 33 to 14, the CVP from 26 to 8, And with all of this, the creatinine dropped from 3 to 1.3. So, with that promising finding, a phase 1 trial was conducted on 18 patients who had decompensated heart failure, worsening renal function, who had been on 48 hours of aggressive diuresis. Most were already on low dose inotropes already and had high wedges and high CVPs. What they found was that the CVP and the wedge went down by about 30 to 40% in all patients except for 2 of them, who were noted to have very high pulmonary artery systolic pressures. Most also were able to achieve a decrease in their inotrope dosing and their diuretic dosing. And this is kind of just another view of that. So you can see 2 didn't go as well, but the rest all had pretty remarkable drops in CVP and wedge pressures. The median creatinine, despite these large enhanced fluid losses, went down from 2 to 1.7. And 30 days later, there was sustained improvement in BNP, creatinine, dyspnea scores. In terms of adverse effects, there were some episodes of bleeding, hemolysis, and vascular injury. Those are all pretty standard adverse effects for mechanical cardiac support devices as well. And one downside is people did need systemic anticoagulation, and this could only be done with ICU level monitoring. Currently, there is a trial ongoing called the DRAIN-HF trial. This is a phase 2 trial where they're looking at 268 patients, and they're randomizing people with the aortic device and diuresis versus diuresis alone. They're going to look at net fluid loss, mortality, heart failure, rehospitalization over 30 days, and tentative completion is September 2025. So looking at this with bated breath, I suppose. So the next pusher device is the Rayton catheter pump, which is the device on the left. So this device goes into the femoral artery, and it's a rotating propeller placed in a similar position in the descending aorta, 5 to 10 centimeters distal to the left subclavian, and it creates a pressure gradient in the aorta so that there's lower pressure proximally, which reduces cardiac afterload, but greater pressure distally to increase perfusion to the renal arteries. And a pilot study was done with 20 patients, similar patient population, HFrEF, decompensated heart failure, low cardiac index. About half the patients needed inotropes. And they did notably exclude patients with significant pulmonary hypertension or RV failure. 2 of the 20 couldn't complete the procedure. They were having problems putting it in. Of the remaining 18 with up to 24 hours of hemodynamic data, the mean cardiac index increased from 1.8 to 2.41. The mean CVP decreased from 21 to 15. Mean GFR increased by 7, and the urine output doubled or tripled. And the study authors proudly noted that 2 patients even qualified for a heart transplant when they didn't, because of the improvement in numbers from the Rayton catheter. The next device in the pusher category is the Module Heart 3 by Puzzle Medical. Now, this is interesting. It's 3 pumps on a single driveline. When you put it into the femoral artery, they have an anchor, an expandable anchor that puts all these pumps in parallel. And it's put, again, similar position, descending aorta above the renal arteries. The idea is that each pump has lower rotational speeds, but together you're going to get a higher flow than you get with most devices without as much shear stress or hemolysis. And they've noted up to 10 liters of flow with this device. So far, this was studied in 4 patients who had high-risk PCIs, so it was PCI assistance with this device. They're found to have 25% increase in cardiac index, 37% decrease in CVP, 78% decrease in end diastolic pressure of the left ventricle, and a 9-fold increase in urine output with no hemolysis observed. Next set of devices are the pullers. So these are the three that are being studied right now. I'll start with the precardia system. The precardia system is a balloon that's put through the internal jugular that intermittently blocks the SVC. The idea with this is you cause rapid reduction in filling pressures. People are a little scared to occlude the IVC because that probably won't be hemodynamically tolerated, as that takes the majority of the blood back into the heart. But SVC is a minority of the blood, and the idea is that if you can occlude it intermittently, you can reduce preload in states of decompensated heart failure. This was looked at in 30 patients, and there were no device-related complications. They found 30% reduction in right atrial pressure and wedge, and about 130% increase in urine output. Next puller device is the Doria catheter. This one is placed in the IVC, but below the renal veins. And the idea is that it creates a pressure gradient in the IVC with a controllable distal frame that can open and close. It temporarily reduces flow from the lower extremities, which puts less pressure on the renal vein and theoretically will improve outflow from the renal vein and thus improve renal perfusion pressure and enhance diuresis. This has been studied in 9 patients with decompensated heart failure and showed a reduction in CVP by 6 with a tripling in the rate of diuresis without a change in blood pressure. Finally is the Nephronics perfuser. This is a device put into the femoral vein, through the femoral vein into the IVC adjacent to the renal veins. And it uses fluid entrainment similar to the aortics device. So you hope to enhance flow out of the renal vein by passively transferring momentum from whatever fluid goes through the pump, and therefore again reducing renal afterload and improving the renal perfusion pressure. There is a small clinical trial underway, but I couldn't find anything on PubMed. Even this slide was taken from a X or Twitter or post because it was presented, I think, at ASN. And then finally, we have interstitium devices, which I'll try to get through very fast. So a healthy interstitium consists of networks of glycosaminoglycan that are designed to create a low compliance system with negative hydrostatic pressure. The idea being that fluid that ends up there doesn't stay there. There's no capacity for it to expand, and it gets pushed to the lymphatics. In states of hypervolemia, you get so much filtration into the interstitium that it starts to exceed the lymphatic reserve. And in decompensated heart failure, we know that there are structural alterations of lymphatic vessels that makes them have less capacity to remove fluid. Plus, you have higher CVP, which impedes outflow from the thoracic duct. So you end up with increased interstitial hydrostatic pressure, and combined with the fact that due to dilution from hypervolemia, you have lower intravascular oncotic pressure, you essentially end up with a vicious cycle. So the two big devices I could find on this are the white swell catheter. This is an axial flow pump. I've been saying that a lot. That creates a low pressure region at the outlet of the thoracic duct. So it's placed at the junction of the left IJ and the subclavian. And almost like a aortic balloon pump, it's designed to enhance lymphatic return from the thoracic duct through the lower pressure gradient and reduce interstitial pressure. So far, it was tested in 1 human with a reduction in CVP and increased urine output. And then finally, we have the Aquapass system. This is, I think we've all sort of fantasized about, well, what if we just make people sweat their fluid out? So someone said, let's do it. So this is a skin suit that raises skin temperature through hot airflow. It stimulates eccrine glands to produce sweat, which is immediately vaporized and flown out. And this essentially does continuous production of sweat, which is designed to reduce interstitial fluid volume. It's passed safety tests, and the couple of humans it's been looked at in, there has been significant weight loss in decompensated heart failure, uh, but a lot more studies need to be done. So finally, I bring to kind of limitations and future questions that this all brings up. So I think it's really important to note that every one of these studies are single arm observational trials. So we really don't know how effective any of these devices are. Um, Randomized controlled trial data is going to take years. We do have the aortic Procerian working on a phase 2 trial, but you can see that a lot of these devices are very early in development. The patient cohorts are pretty small. The duration of follow-up in general has been pretty small, and the duration of device use has been limited to a few days at most, sometimes less than 24 hours. But let's say these devices prove to really work well. Who's going to be a good candidate? Anybody with worsening renal function? Anybody with decompensated heart failure? Should it be reserved to patients with uh, significant diuretic resistance? How would you define that? Would you use pressors or inotropes first? Or do these devices offer benefits that would preclude using those inotropes if you can get away with it? Will there be long-term benefits beyond what we see in the index admissions? We still don't even know how to really define euvolemia or assess blood volume. So how do we really assess outcomes? I mean, that's a problem with cardiorenal data in general. And then will things like hemolysis and bleeding and vascular injury become bigger issues than we can see with these smaller studies? And is that going to end up being a preclusion? So really exciting stuff. Um, yeah, thank you, everyone.
Very good, David. Thank you. That's really interesting. I didn't know a lot about these devices on the horizon, so thank you. Um, I think we may have time for maybe one or two questions before we get going on our next talk, just because we ran over a little bit. Let's see here. Looks like in the chat, Galyuan, does the AquaPath system work like a sauna room as an increasing skin temperature and increased sweating?
So, yeah, essentially, I mean, I think the idea is that with a sauna, um, you don't really have like airflow that's going to remove your sweat. With the aquapath system, the concept is you have this constant heated airflow so that it gets cycled out of the suit itself. Apparently that kind of stimulates the glands to create more sweat more quickly over time. So it would be like a super powered sauna designed to enhance sweat.
Very good. Yeah, it looks like lots of praise in the chat. Kind of
Thank you,
along the
everyone.
lines of Kim mentions outstanding, David. So let's get UW Nephrology involved in trials and designs.
Mhm.
I guess my only question would be, do you foresee us being involved in any of these trials? Have you heard anything on the horizon, and do you know if so, which of these devices we may see soonest?
So I have not really heard anything. I haven't reached out to anyone to any of the manufacturers. I've looked a little bit into the companies. So right now I don't really have any info on that, though I do think it would be really cool for us to get involved. In terms of which devices I could see um, being first in line, currently the aortic Procerian is the one that's moved the most ahead. That has the first phase 2 trial going on. Everything else is either phase 1 or kind of concept pilot trials in humans, but the Procerian is actually getting the first randomized trial that I could find. I could be wrong, but that was what I found when I did a literature search.
All right. Thank you. Just one last quick question, and I think we'll move on to the next talk. From Lily, she mentions, this is really awesome. Thank you. Who do you think places these intravascular devices? As in, is this done by IR versus is this a field for maybe interventional nephrology to even be involved?
Yeah, great question. So I think it's going to be different for different devices. For some of the puller devices that go into the veins, I could see IR doing that. Some of the pusher devices like the Procerion are going to be, I think a little bit beyond the scope of IR, because they have drive lines. I could see that being similar to LVADs, where you might really need a cardiac surgery involved. Um, Interventional neph, I mean, I don't know. I mean, I think it's certainly a prospective. It's good prospects for interventional neph, at least for some of those puller devices, if those start to expand.
All right. Well, thank you again. Really fantastic talk. And are
Mhm.
there any other questions? Maybe we can move forward in the chat.